using a computerized system. And basically, I will just have a brief introduction about the topic itself, knowing about what we call the pathophysiology of pulmonary embolism, where the RV arterial load becomes the landmark manifestation of at least submassive to massive pulmonary embolism with RV dilatation, neurohormonal activations, oxygen demand increase, RV ischemia, RV contractility problems, LV preload problems, low cardiac output, all the way down to the severe of it. Now, a clinical decision to consider the diagnosis has been given original version with so many points included based on the precipitating causes like surgery, active cancer, prothrombotic situations, etc., and also related to the what you call the probability of being a high, low, or intermediate level of severity, further simplified to become more easier to handle in the newer version. Now, the technology started in 2013, 2014 with the catheter-based thrombectomy device has eventually used a computerized system, and that resulted in the currently used system. If you look here, you see how it works. Should actually work automatically. And you'll see that it is the computer will actually decide whether or not it will suck, as opposed to, you see, whenever the catheter tip do not have a clot against it, it will stop only to restart again. This have helped to reduce the amount of bleeding or blood suctioning during the process and reduce the total blood loss to lower levels. In this comparative study, this is not a head-to-head comparison between Extract PE, the randomized trial, and Seattle of anticoagulation systems. Clearly, there was a primary safety favorable outcome, major bleeding outcome, and hospital stay outcome benefit. And these are just considerations of cases where you can see here in the right pulmonary artery before and after, where the large thrombi have practically blocked the upper part of the right lung and similarly part of the left. And then you can see here it can be used in order to reduce thrombotic origin of the problem from the iliofemoral veins, where it can actually remove and treat, basically giving you the best of the possible. And this again depends on the availability of the thrombus, and the suctioning process is governed by the computer. Based on the data that the guidelines in 2014, 2019 have recommended, it showed certainly that since the 1990s, the rate at which the pulmonary embolism was increasing across the world, different countries, while actually, since that time onwards, the treatment have emerged or managed to improve outcome significantly. Now, this is the guidelines at that time showing rescue thrombotic therapy is now becoming class 1 as opposed to 2014. Surgical embolectomy 2A, D-dimer measurements and clinical prediction rails 2A, and evaluation to be given for CTE-PH. As you know, it may not be considered. However, if considered, it has to be pre-evaluated and see the appropriateness of the patient. This is the study STORM-PE, that first randomized trial published at TCT 2025, and clearly have shown primary outcome events favorable, safety outcome favorable, and procedural data favorable outcomes. And in this real-world safety performance prior publication also showed similar outcome results with the duration of the procedure, with similar other what you call RV-LV ratio changes, systolic pulmonary artery pressure, and of course, MACE, all in all, in favor. I will go you the 3 types of cases. The first one is the worst of them. This is a 23-year-old female, previously cavernous sinus thrombosis. It just tells you why should a 23-year-old female have it, probably because of her prothrombotic setups, nephrotic syndrome. And actually, at that time, she was on DOAC, apixaban 5 milligram, whether appropriately or not, we will not discuss it now. Patient presented with worsening dyspnea, chest discomfort, dizziness, and vomiting. Patient upon presentation was critically ill, desaturated rapidly, became hemodynamically unstable with severe metabolic acidosis. At that time, a patient was admitted under ICU. She was diagnosed as acute massive pulmonary embolism with evidence of right ventricular dilatation, dysfunction, and extremely high D-dimer levels. Patient admitted under general ICU received systemic thrombolysis. However, patient remained hemodynamically unstable on maximal multiple inotropic support and intubated. This was around 1 a.m. In the morning. Shortly after that, when they realized the patient is not getting any better, they called us to see what can we do and consider a life-saving intervention. At that time, we arranged for mechanical thrombectomy. Actually, the patient was planned to go to the radiology department. In her critical condition, I decided not to take her there, just to take her straight to the cardiac cath lab. This was her echo before. You can see the ratio of the RV to the LV remarkably higher. Now, at that time, upon arrival, we arranged for pulmonary angiography to be done. And then basically, as we started, patient became progressively worse, severely hypotensive, and in shock. And only to develop after that a relatively short cardiac arrest, asystolic cardiac arrest, responded to CPR and ROSC. Now, at that time, we were securing access, right femoral vein, percutaneously, using 6, 8, 10, and 12 French for the actual penumbra sheath, using mother and child technology. And then it was actually difficult to reach the pulmonary artery without this technique. Systemic prompted, started thrombus aspiration, started with the right pulmonary artery, followed by thrombus aspiration in the left. And basically, this is what we found. The left system, you can see proximal filling defects. The right system, again, large, upper, middle, and lower defects, and more definite. Practically only the middle right lung is perfused. And here I had to end up suctioning. It started immediately on the right, and it took a little effort to be done by using the wire to manipulate and disintegrate the clots. Marginal improvement initially. Of course, patients are extremely unwell. And this right upper lung reperfused. Now right lower lung. And reperfused to a degree. Then left pulmonary, similar. And again, this took from the time I finished the left to the time I returned to the right to see where we are, only to discover that the patient reformed a huge, large filling defect, as you see it here, clearly in this situation here, and total blockage of the upper. And at that time, we increased her inotropic support to double type and tried to win again. So we went back and basically started the same process again and again, indicating that this patient is regenerating the thrombi in situ. And that became the biggest challenge for this patient. And I continued the work. Anyway, with re-emerging thrombotic formations, particularly over the right upper and to a degree to the other parts, then I proceeded with locally delivered thrombolysis. It is not the typical technique, but this is at least something to be done for this lady. And at that time, although she received full thrombolytic therapy at 1 a.m., this is around 7 a.m., the APTT was normal, so we agreed to continue. Lysis was given, and then followed by a infusion over 12 to 24 hours. Patient, during all this period, became severely hypotensive with boluses of epinephrine, norepinephrine, and towards the end of the procedure, patient stabilized gradually, satisfactorily with hemodynamics, and managed to go on lower levels of norepinephrine only. Follow-up echo done 6 hours after the procedure showed some improvement of the RV compared to the left ventricle, but unfortunately this patient already had multi-organ failure, shock state, hepatorenal encephalopathic, hematologic, DIC injury, required hemodialysis, required transfusions, required maximally delivered supportive therapy, and unfortunately by day 4 of her managing care, she passed away. My second case is a 30-year-old.
1 minute, please.
1 minute. A 30-year-old female, complicated delivery by forceps, vacuum extractor, significant desaturation, hypotension, cardiac arrest, pelvic bleeding. So you can tell the combination of pelvic bleeding, ongoing, and pulmonary embolism, diagnosed and consulted. And again, same thing, large filling defects, you can see, and with right and the left as well, manipulated, suctioning throughout the time. And this was her RV at the start, with bubble study also confirmed. And then after 24 hours, much less tachycardia, improved RV, etc., and IVC. Case 3 is a 25-year-old female presented 1 week post-liposuction procedure prior 2 weeks. And with that, she developed severe dyspnea, leg swelling, etc. CTA was done 4 days after, confirmed the diagnosis of multiple defect, provoked right ventricle popliteal vein thrombosis considered, and then the last image.
Yeah.
Basically, it says the patient actually was treated with an ecosystem at that time, and these are hemodynamics initially. And this is a presentation time, and basically just want to show you that her RV completely recovered as well. So in summary, this patient underwent a successful intervention. This is the beginning. And this is the ecos, bilateral, filling defects, all improved, and of course was remarkably improved. And this is her RV after 1 month. Thank you.